Hello everyone, and thank you for being here. I'm Dr. Disha Baxi, consultant anesthesiologist at AIG Hospitals, Hyderabad. Today's session will explore the intricacies of the lumbosacral plexus block, a regional anesthesia technique particularly useful in patients where neuralgial blocks are contraindicated or inadvisable. We will cover the anatomical background, indications and contraindications, landmark based and ultrasound guided techniques, including both lumbar and sacral plexus approaches, and address potential complications and troubleshooting. By the end of this session, you should feel confident in selecting and safely executing these blocks in appropriate clinical scenarios. Let's begin by discussing a case we recently received at AIG hospitals. A 68-year-old male is posted for open reduction and internal fixation of the right tibia. He has a recent history of right pulmonary embolism and is currently receiving subcutaneous heparin 5000 units twice daily. This rules out central neuraxial anesthesia due to bleeding risk. General anesthesia carries its own concerns, particularly in someone with a possible underlying cardiopulmonary compromise. In this patient, a combined lumbosacral plexus block is an ideal choice. It offers both surgical anesthesia and postoperative analgesia while maintaining hemodynamic stability. Now let's discuss why a lumbosacral plexus block. There are several compelling reasons to choose this block in such scenarios. It provides comprehensive anesthesia to the lower limb. It preserves cardiovascular stability, which is crucial in patients with low ejection fraction or recent cardiac events. It allows the use of a tourniquet if needed. Unlike central neuraxial blocks, this can be safely used in septic patients. It provides prolonged postoperative analgesia lasting more than 8 hours, which reduces opioid consumption and promotes early mobilization. We shall now proceed to understand the anatomy of the lumbar plexus. The lumbar plexus is a network of nerves formed by the ventral rami of L1 to L4 spinal nerves with occasional contribution from T12 or the subcostal nerve. It is located within the posterior part of the psoas major muscle, anterior to the transverse processes of lumbar vertebra. From superior to inferior, the six major branches are iliohypogastric nerve, ilioinguinal nerve, genitofemoral nerve, and obturator nerve anteriorly, and posteriorly femoral nerve and lateral femoral cutaneous nerve. With this background, let us proceed to knowing more about the lumbar plexus block. Dr. Vinny first described this technique in 1974 using the PSIS intercrystal line. It was later found to be too lateral, leading to inconsistent blocks. In 1976, Cheyenne improved accuracy with 5 cm lateral, 3 cm caudal approach to L4 spinous process using loss of resistance, but it was still landmark based. In 1989, Parkinson used L3 3 to 4 cm lateral with nerve stimulation, but this carried a renal injury risk due to high and deep needle path. In 2002, Capdevia modified Vinny's point, going 1 cm medial for better targeting, yet being lateral enough to avoid the central spread. In 2002, Pandin went to 2 medial, increasing the risk of epidural spread. In 1993, Mansoor described a parasacral approach targeting sacral plexus, which was helpful for combined blocks. And finally, in 2001, Kirschmeyer introduced USG guided technique, which was a major advancement, though visualization still remains limited because of the deep position of the plexus. Lumbar plexus block is indicated for lower limb procedures like surgeries for femoral fractures and procedures around the knee joint and anterior thigh. However, since it is not blocking the sciatic nerve, it cannot be used as a sole anesthetic technique for major surgeries of the lower extremity. Lumbar plexus block is absolutely contraindicated without consent of the patient. If a patient has a history of allergy to local anesthetics, if there is infection at or around the site of scanning or needle entry, or if the patient has coagulopathy with INR more than 1.5. It should be reconsidered or used with extreme caution in cases which have any kind of spinal implantation, like an intrathecal pump, spinal cord stimulator, implanted hardware, or a deformed spine either from disease or major surgery. In prior retroperitoneal surgeries, also because of likely distortion of anatomical planes and in the presence of pre existing neurological deficits, as assessment of block becomes difficult, as well as for medical legal concerns. The methods of lumbar plexus block we will be discussing now are the PNS guided ones. Traditionally, lumbar plexus block is performed using surface anatomical landmarks to identify the site for needle insertion and eliciting quadriceps muscle contraction in response to nerve electrolocalization. However, the depth at which the lumbar plexus is located is a challenge, as is the size of the plexus, which requires a large volume of local anesthetic for success. The position required is lateral decubitus with a slight forward tilt. The foot of the side to be blocked should be positioned over the dependent leg so that twitches of the quadriceps muscle and or the patella can be seen easily. After obtaining patient consent, attaching monitors and confirming site and site of the procedure, one should make sure all required equipment is at hand, namely a USG machine with sterile probe cover, sterile drapes and gloves, antiseptic solution for sterilizing the block surface, sterile scale and marker, local anesthetic and a 5 cc syringe and 1.5 inches 25 gauge needle for skin infiltration, TNS and ECG leads for earthing, 10 centimeter long short bevel insulated needles, local anesthetic for block, 20 cc syringes, emergency drugs, and intralipid emulsion. The PNS setting we will be using in all PNS guided blocks in this discussion are current of 1.5 milliamperes, a frequency of 2 Hz, and an interval of zero point 0.1 milliseconds. Upon eliciting the required motor response, we shall reduce the current to 0.2 to 0.5 milliamperes. At the outset, we'll be drawing the following 3 lines. Line 1 will be an intercrystal vertical line between the highest points of the iliac crest. This is the vertical intercrystal line. Line 2 will be a horizontal line passing through the spinous processes of L4 and L5 vertebrae. As you can see in the video, we are now in the process of drawing the interspinous line 2. And line 3 will be parallel to line 2, passing through the posterior superior iliac spine. So these are the 3 landmarks which we will be using for both Winnie's and Capdevia's approach. Coming to Capdevia's approach, the part of the intercrystal line between lines 2 and 3 is divided into 3 parts. The puncture point is the junction between the lateral and the middle third. After cleaning with antiseptic solution, the skin is anesthetized by infiltrating local anesthetic subcutaneously. A 10 centimeter needle is inserted at a perpendicular angle to the skin with the PNS set to deliver a current intensity of 1.5 milliamperes. The needle contacts the transverse process at 6 to 8 centimeter depth. This depth is noted, the needle is withdrawn and reinserted by directing it 5 degrees cranially or caudally to pass its tip beyond the transverse process until the evoked motor response or patellar twitch is obtained. The needle should not be advanced more than 2 centimeters beyond the transverse process. This is the desired response, which is the quadriceps twitch upon stimulating the lumbar plexus in the substance of psoas major. For Vinnie's approach, the puncture point is at the junction of lines 1 and 3. The needle is inserted at the intersection of these lines with a slight medial inclination. It should be between the transverse processes of L4 and L5. The needle can be redirected caudally if the transverse process of L5 is encountered. Vinnie's technique is still widely in practice, although the medial angulation of the needle is difficult to control and can easily lead to epidural or subarachnoid placement. Even with Vinnie's approach, the desired response will be the quadriceps twitch. To assess the block, in 15 to 20 minutes, the first sign of onset we can expect is loss of sensation in saphenous nerve area, followed by pain relief on rotational movement. The patient will soon be unable to extend the blocked leg because of quadriceps weakness. For troubleshooting of the block, if you find that there is a local twitch of the paraspinal muscles, then it means that you are directly stimulating them, in which case the needle is too shallow and we should continue advancing the needle. If the needle contacts the bone at 4 to 6 centimeter depth but without any twitches, then it means that the needle has hit the transverse process. In this case, the path of the needle is correct. We just have to withdraw to skin level and redirect at 5 degrees cranially or caudally. If hamstrings show twitches, then it is because of stimulation of the sciatic nerve, in which case the needle is too caudal. Withdraw the needle and reinsert 3 to 5 centimeters cranially. If the thigh is flexed, it can be a missed response because of direct stimulation of the psoas muscle. It means the needle is too deep. Stop advancing the needle, withdraw, reinsert again. If the needle is placed deep at about a depth of 10 centimeter, but still there are no twitches elicited and even transverse process isn't contacted, then the needle has missed the transverse process and the lumbar plexus. It may be too lateral. Withdraw and reinsert with a slight medial angulation of 5 to 10 degrees. Let's now discuss USG guided lumbar plexus block. Depth of the lumbar plexus necessitates the use of low frequency and curved array transducers to image anatomy. Low frequency ultrasonography provides good penetration, but it lacks spatial resolution. Hence, it is prudent to use PNS in conjunction with USG for nerve localization during USG guided lumbar plexus block. In the paramedian sagittal scan, on a sagittal sonogram, the lumbar transverse processes are identified by their hyperechoic reflection and an anterior acoustic shadow, which is typical of bone. The acoustic shadow of the transverse process produces a sonographic pattern referred to as the trident sign. These are the tridents. An insulated nerve block needle connected to a nerve stimulator is inserted in plane from the caudal end of the USG transducer. The aim is to guide the block needle through the acoustic window of the lumbar USG trident, that is, through the space between the transverse processes of L3 and L4 into the posterior aspect of the psoas major muscle until either needle nerve contact is visualized or an ipsilateral quadratus muscle contraction is elicited. For the Shamrock method, a transverse scan is performed at the flank and immediately above the iliac crest. Once the sonographic pattern of the Shamrock is obtained, at the level of the L4 transverse process, the USG transducer is tilted slightly caudally until the acoustic shadow of the transverse process is no longer visualized. A line is then drawn on the patient's back, extending from the center of the transducer to the midline of the back. A nerve block needle is inserted 4 cm from the midline along this line and gradually advanced anteriorly until the needle tip is close to the L3 nerve root. After confirming with nerve stimulation, the 20 to 30 ml of local anesthetic is injected slowly in aliquots. A unique challenge of lumbar plexus block is that it is a highly vascular area because of the ascending lumbar veins and lumbar arteries, the dorsal branch of lumbar artery, and so all of these increase the chances of a psoas hematoma. In the elderly, the echo-intensity of skeletal muscles is significantly increased, which can make the block challenging. Upper lumbar nerves L1 and L2 contribute predominantly to sensory nerves, and stimulating these may not elicit a motor response. Moving on to sacral plexus block, a little about the anatomy of sacral plexus first. The sacral plexus arises from the lumbosacral trunk L4 to L5 plus the ventral rami of S1 to S4. The main nerves of the sacral plexus are the sciatic nerve and the pudendal nerve. The sciatic nerve leaves the pelvis through the greater sciatic foramen to enter the gluteal area, where it travels between the greater trochanter and the ischial tuberosity. The other nerves are the superior and inferior gluteal nerves, posterior femoral cutaneous nerve, all of which supply muscles and skin over the lower limb and the genital region. We'll now discuss the indications of parasacral sciatic nerve block. It is used in combination with lumbar plexus block for lower limb surgeries and in anesthesia for high amputations and for relief of sciatic pain. It is also used when immediate access to individual nerves is not possible owing to trauma or infection. Coming to Mansoor's PNS guided parasacral approach, this approach to sciatic nerve is a true sacral plexus block because here the injection of local anesthetic is in the facial plane around the branches of the entire sacral plexus before the sciatic nerve is formed. The positioning will be the same as for lumbar plexus block, except that in this case, we'll have to keep the foot uncovered because the end point is plantar or dorsiflexion or eversion of the foot. A line is drawn between the posterior superior iliac spine and the lowest point of the ischial tuberosity. The needle insertion point lies 3-finger breadth or 6 centimeter inferior to the PSIS on this line. After all aseptic precautions and local anesthetic infiltration of skin, a 10 centimeter needle is inserted at the marked point perpendicularly. We'll now mark 6 centimeters along this line from the PSIS, and that will be the needle insertion point. Plantar flexion of the foot or toes if the tibial component is stimulated, dorsiflexion or eversion of foot or toes if the common peroneal component is stimulated. These are the responses sought. The mean depth of the needle insertion is about 7 centimeters and a volume of 15 to 20 ml of local anesthetic is sufficient. Ultrasound guided parasacral ischial plane block is a facial plane volume block which is easy to perform, safe as it is located away from vascular and neural structures and the bowel. It is useful in situations where neurostimulation cannot be performed, like in case of amputees. The patient is in lateral position and the site to be blocked is uppermost. After drawing a line joining the greater trochanter of the femur to the ischial tuberosity, a 2 to 3 MHz curvilinear probe is used. It is positioned medial to the midpoint of the line joining the greater trochanter to PSIS. The probe is then moved gradually from the supralateral to inferomedial direction, what is known as the parasacral parallel shift. This is the parasacral parallel shift being performed. As we move from the supralateral to the inferomedial direction, initially we'll be able to see the wing of the ilium on USG picture below the gluteus maximus and medius muscles. Progressing downwards till the ischium will come into view. This is known as the toucan appearance because the wing of ischium resembles the bill of the toucan bird. Over here, we'll be able to see the sciatic nerve root, which is where we would like to place our injection. This is where the sciatic nerve will be located. Upon getting this picture, you can then proceed to insert an 80 to 100 mm short bevel needle in plane. The end point is needle contact with the posterior border of ischium. 20 ml of local anesthetic is then injected at this point. The LA injected spreads medially under the piriformis to surround the sacral plexus. To return to the case we started with, we performed a lumbar and sacral plexus block. The method we used for lumbar plexus block was the shamrock method. Upon eliciting quadriceps twitches, we proceeded to inject 20 ml of 0.2%, 0.5% ropivacaine. For the sciatic sacral plexus block, we used Mansour's parasacral approach, PNS guided. And upon eliciting dorsiflexion, we proceeded to give the injection.
Which is also going. Give.
We then tested the efficacy of the block using cold sensation, followed by deep pressure, pinprick, and finally surgical stimulus. This is the patient comfortable during surgery and requiring no supplemental general anesthesia, and the vitals of the patient during the surgery. We've also published a paper through our department on non-neuralgial regional anesthesia technique for hip surgeries, with the primary objective of achieving complete sensory and motor blockade to the patient using lumbar and sacral plexus block. These are my references for the presentation. Thank you for your attention. Lumbosacral plexus block, though technically demanding, it is an invaluable tool in modern anesthesia practice. It offers reliable regional anesthesia in high-risk patients and enables excellent post-operative pain control. Thank you.